Thank you very much for inviting me to this fantastic meeting. My topic is other potential mechanisms for the beneficial cardiovascular effects of SGLT2 inhibition. Well, all what we really know really with respect to outcomes comes from clinical trials. And therefore, I would like first to look at implications from these trial data. You know, the EMPERIC outcome study with 7,000 patients, type 2 diabetes plus established cardiovascular disease. They were randomized to empagliflozin or placebo, followed up for 3 years, and the primary endpoint was a composite of cardiovascular death, myocardial infarction, and stroke. And this primary outcome was significantly reduced by 14% with a number needed to treat of 63. Also, cardiovascular death was reduced very markedly, more than 30%, and total mortality was reduced with empagliflozin. When we look at further endpoints in this study, we somewhat surprisingly see that there was no significant reduction in atherosclerosis-related endpoints, which typically drive these composed primary endpoints in cardiovascular outcome trials. So no reduction in myocardial infarction, no reduction in stroke. However, as mentioned previously, there was a strong reduction in the hospitalization for heart failure. Now, heart failure is a clinical syndrome, and pathophysiologically there are several types of heart failure. Basically, we can divide the condition into heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. We do not know from the trial data exactly which type of heart failure was to be prevented here and was the basis for the heart failure incidence. However, when we look at this paper where mortality and heart failure hospitalizations were compared between hypertension trials in blue, heart failure with preserved ejection fraction trials in red, heart failure with reduced ejection fraction trials in green, and on the right-hand side in the EMPERIC outcome trial, we see that total mortality and heart failure hospitalizations were similar in EMPERIC outcome as in the trials with heart failure with preserved ejection fraction. And this is what we also had previously known, that especially in patients with diabetes, the prevalence of heart failure with preserved ejection fraction is really high. And up to now, we did not have really a treatment modality to efficiently intervene in these patients. Potentially, SGLT2 inhibitors may help here. Now, the cardiovascular benefits of the SGLT2 inhibitors are independent in the trials from a history of heart failure, above the subgroup analysis from the EMPERIC outcome trial, and below subgroup analysis from the CANVAS program. You see, no significant interaction with respect to a baseline history of heart failure. Now, the CANVAS trial, this was the other great published SGLT2 trial with over 10,000 patients randomized to canagliflozin versus placebo. Again, the primary endpoint of cardiovascular death, MI, and stroke, and mean follow-up here of 3.6 years. Again, a significant reduction also by 14% with canagliflozin versus placebo, number needed to treat of only 27. In CANVAS, there were also patients who did not have established cardiovascular disease, and in subgroup analysis, in this subgroup of patients who had risk factors but not established cardiovascular disease, no significant impact of canagliflozin on the primary endpoint was observed. However, a clear benefit was observed in the subgroup of patients with established cardiovascular disease. This group had composed all the study cohort of empagliflozin in the EMPERIC outcome trial. Now again, a look at specific endpoints, and outstanding again in the CANVAS trial with canagliflozin, the hospitalizations for heart failure, like in EMPERIC outcome, no effect on macrovascular endpoints on MI and on stroke. Now, what stands behind this? We have an effect on mortality, we have an effect on heart failure hospitalizations, but what might explain this? Now, this is a recent paper summarizing potential mechanisms which are currently in debate. And basically, we can divide these mechanisms into systemic effects and direct cardiac effects, with, of course, many overlaps. Now, the heart in diabetes typically is involved and is not healthy. And here we find typical features of cardiomyopathy in patients with diabetes: left ventricular hypertrophy, increased apoptosis of cardiomyocytes, impaired cardiac metabolism, as we have heard before. Now, potentially, SGLT2 inhibitors can transform this sick heart into a healthier heart, in a better functioning heart. But, as also has been mentioned before, SGLT2 inhibitors primarily do not address the heart, but the kidney. You know that 90% of glucose is reabsorbed in the proximal tubulus, and this is where SGLT2 inhibitors primarily work. They hinder the reabsorption of glucose and of sodium in the proximal tubulus. More glucose, more sodium runs out down the nephron. And this, of course, has an impact on tubuloglomerular feedback and leads to a constriction of the vas afferens. This is basically how SGLT2 inhibitors work, and of course, it is very likely that this will also impact their effect on cardiovascular prognosis. I'll come to that. Now, these are drugs which are given to lower glucose. These are anti-diabetic drugs. May glucose lowering be a reason why SGLT2 inhibitors reduce hospitalizations for heart failure, cardiovascular mortality? Now, there may be glucotoxicity. Hypoglycemia may lead to an uptake of glucose in cardiac myocytes beyond their oxidative capacity, and this may be counteracted by SGLT2 inhibitors. However, this is not counteracted by other glucose-lowering drugs, which don't have an effect on cardiovascular outcomes. Then in empiric outcome, there was a weak reduction in HbA1c of below 0.5%. This does not mean that empagliflozin is a weak glucose-lowering agent, but the comparator was standard treatment of type 2 diabetes, and therefore there was not a strong difference in HbA1c between placebo and empagliflozin in the empiric outcome trial. Further, when we look at subgroups by baseline hemoglobin A1c, we find that those with higher baseline HbA1c not at all benefit more from empagliflozin compared to those with lower HbA1c. So it's not likely that glucose lowering explains the effect behind the protection of the heart by SGLT2 inhibitors. And finally, there is also no impact on the baseline, on the cardiovascular outcome by the baseline glomerular filtration rate. If really glucose lowering would explain the cardiovascular risk reduction, this should be expected because the glucose lowering potency of SGLT2 inhibitors is strongly dependent on the baseline eGFR. So it's unlikely that glucose lowering is the carrier of the effect of SGLT2 inhibitors of the heart. However, as pointed out previously, these medications don't only lower glucose, they have a very profound effect, a systemic effect on metabolism. Glucagon is increased, ketogenesis is increased, appetite regulation is affected. Also, the metabolism of the fat is profoundly influenced. And finally, substrate utilization, of course, in the heart is affected. So it's not glucose, but it may well be a metabolic effect, at least in part. Another issue is weight loss. SGLT2 inhibitors cause weight loss. And these are data from the empiric outcome trial, an overall reduction in 2 kilograms of body weight. Also, waist circumference is a bit reduced by 2 centimeters. However, in the look-ahead trial, which was a lifestyle trial in patients with type 2 diabetes, we had a stronger reduction in body weight, but no effect at all on the cardiovascular outcome. So it's not likely that weight reduction accounts for the effect of SGLT2 inhibitors. What about blood pressure lowering? Indeed, empagliflozin reduces blood pressure quite markedly, so 4 millimeters of mercury, which is comparable to classic antihypertensive drugs, but not extremely strong. Now, this may be explained through an impact on the renin-angiotensin system in heart failure. There is a decreased blood flow and increased reabsorption of sodium in the proximal tubulus, which is linked to neurohumoral activation and may be counteracted by SGLT2 inhibitors. And also volume contraction may contribute to the blood pressure lowering effect of the SGLT2 inhibitors. And in addition, there is a direct effect on the vasculature. This is a recent study which shows that here with dapagliflozin, flow-mediated dilatation increases when compared to placebo, then the pulse wave velocity decreases, and also the renal resistive index decreases. So there is an impact on arterial stiffness. Arterial stiffness is reduced by SGLT2 inhibitors, which may reduce blood pressure with these medications. But does blood pressure reduction explain the cardiovascular benefit of SGLT2 inhibitors? Well, if this were the case, we would expect a reduction in the risk of stroke, because this is the first thing what typically happens when blood pressure is lowered. Then the magnitude of the effect is more than 30% of reduction in mortality is of course not explained by a slight reduction in blood pressure. And further, the time course of effects does not fit to the hypothesis that blood pressure lowering explains why cardiovascular events are reduced with SGLT2 inhibitors, because the effect was very early, and with blood pressure lowering, blood pressure trials, the effect was much later on in the treatment course. Now, cardiac loading conditions are extremely important, especially in the already sick heart, especially in heart failure. And SGLT2 inhibitors lead to an improvement in cardiac loading conditions. Now, they lead to volume contraction, which is reflected by about 5% increase in hemoglobin, and this is not merely due to natriuresis. 24 hours after treatment, the sodium excretion is on pre-treatment levels. It's also not merely an osmotic effect of glucosuria, because similar effects are noted in individuals without diabetes when compared to patients with diabetes, and similar effects are observed in patients with a reduced EGFR when compared to patients with a normal EGFR. And glucosuria, of course, is much higher in those with a higher EGFR. Also, an empiric outcome, cardiovascular outcome, was similarly improved in subjects with reduced as in subjects with a higher EGFR. Now, hematocrit is increased in patients receiving SGLT2 inhibitors, which is probably due to reduction in plasma volume, but there may be an additional mechanism, because especially in heart failure, there is tubulointerstitial hypoxia, and if this is reduced by SGLT2 inhibitors, this may lead to stimulation in erythropoiesis, and therefore also from this mechanism to a higher hematocrit, and in turn to a better tissue oxygenation. There is a recent paper in Diabetes Care where elegant mediation analysis were performed. Mediation analysis is a mathematical technique which looks at which parameters change with a medication and also have an impact on the outcome. And then the effect conferred by changing these variables is subtracted from the change inferred by the medication itself. And when the effect of the change, if you subtract it from the effect of the medication, leads to a huge difference in effectiveness of the power of the medication, then a huge amount of the mechanism may be explained why the medication reduces cardiovascular events. And here in these mediation analyses, the effect of empagliflozin in empiric outcome appear to be strongly mediated by increases in hematocrit. More than 50% of cardiovascular deaths reduction were mediated by change in hematocrit, were explained by a change, by an increase in hematocrit. This, of course, is not a definite proof, but shows a strong link, a strong association between the increase in hematocrit and the reduction of cardiovascular death risk in the EMPEROR outcome trial. Importantly, we've already a bit discussed this, SGLT2 inhibitors are not at all the same as loop diuretics, because loop diuretics, here on the right-hand side, mainly lead to a reduction in intravascular volume, whereas intravascular volume is not that much changed by SGLT2 inhibitors. SGLT2 inhibitors more lead to a reduction in interstitial volume, and this may have beneficial effects, especially in patients with heart failure. Now, apart from volume changes, there are other potential benefits regarding loading conditions which may be mediated by SGLT2 inhibitors. Blood pressure reduction, as mentioned previously, then the improvement of endothelial function is also discussed, and then the vasodilatation through activation of voltage-gated potassium channels and protein kinase G, as also has been mentioned already in the introduction. So there's quite several lines of evidence which point to a very strong impact on cardiac loading condition and a beneficial impact on cardiac loading conditions with SGLT2 inhibitors. And given that these loading conditions are extremely important, especially in the failing heart, this is very likely a major mechanism behind the beneficial effect of SGLT2 inhibitors. Now, what about kidney function? You know that SGLT2 inhibitors not only improve cardiovascular prognosis, but also kidney function. Here you see the time course of eGFR with empagliflozin versus placebo. Well, eGFR goes down both with placebo treatment and with empagliflozin, but the decline is much stronger in patients not receiving empagliflozin. So empagliflozin is nephroprotective. And also the endpoint of incident and worsening nephropathy was markedly reduced with treatment with empagliflozin when compared to placebo. Indeed, the effect was even stronger than the effect on the heart outcomes. Now, the classical nephrological endpoint of doubling of serum creatinine, initiation of renal replacement therapy, and death upon renal disease was reduced by almost 50%. So very strong impact, a beneficial impact of empagliflozin also on renal disease. And this was not only carried by weak or soft endpoints, but really through the continuum of nephrological endpoints. Now, we can explain this, I think, better than the impact of empagliflozin or other SGLT2 inhibitors on cardiovascular outcome, because in diabetes, the vas afferens is dilated, and this leads to glomerular hyperperfusion. In the consequence, there is fibrosis within the glomerulum, and this leads to diabetic kidney damage. And if you constrict the vas afferens, this will alleviate the pressure on the glomerulum and will save your kidneys from further deterioration. So this is a quite well explainable effect of the medications on kidney function. Improved kidney function, in turn, may well improve the functioning of heart, so through a reduction in salt and water retention, for example. Declining kidney function, as we have shown in a paper published recently, is a strong predictor of future cardiovascular events. And again, also when the heart is improved, the kidney will have beneficial effects from that. So less oxidative stress, less congestion will lead to improved kidney perfusion, to improved kidney health. Now, what about direct cardiac effects? I'll not mention the metabolic effects here because they have been discussed very elegantly previously, but there are other effects on the myocardium which appear possible. There has been a hypothesis that an inhibition of a myocardial sodium-hydrogen exchange may be beneficial, and there are some data that a prevention of myocardial fibrosis might be a mechanism behind the beneficial effect of SGLT2 inhibitors. What about this sodium-hydrogen hypothesis? Now, in the heart, there are sodium-hydrogen exchanges which are upregulated in patients with diabetes and lead to an increased intracellular calcium, but a decreased intermitochondrial calcium amount, and therefore to muscle deterioration. And the concept is that SGLT2 inhibitors may, by some mechanism, inhibit these upregulated sodium-hydrogen exchanges and therefore improve cardiac function. However, in the heart, there are no SGLT2 receptors. That would be kind of a pleiotropic effect of the medication, and currently this is mainly a hypothesis which is not extremely strongly backed up by data from physiological observations. What about the prevention of myocardial fibrosis? Now, myocardial fibrosis is a key mechanism both in heart failure with preserved and in heart failure with reduced ejection fraction. Here we see the basic mechanism of heart failure with preserved ejection fraction, which is a deterioration in endothelial dysfunction, but this deterioration is accompanied, is more pronounced through the effect of hypoglycemia and lipids on the fibroblasts, which lead to an interstitial reactive fibrosis. And also in heart failure with reduced ejection fraction, there is cell death as the major mechanism, so apoptosis of cardiomyocytes as the basic mechanism, but here we have replacement fibrosis, which also contributes to the deterioration of the function of the myocardium. And there are some data, not too much, but some, which show that SGLT2 inhibitors in a rat model and also in humans may counteract fibrosis in the heart. Now, there are several further considerations regarding potential mechanisms behind the beneficial impact of SGLT2 inhibitors on cardiovascular prognosis. One is decreased uric acid. Indeed, in these mediation analysis, which I've presented before, also a decrease in uric acid mediated some of the effect of SGLT2 inhibition. And indeed, high uric acid is associated with oxidative stress, activation of the renin-angiotensin system, and hypertension. And SGLT2 inhibition reduces uric acid via the reduction of reabsorption of uric acid via GLUT9 through an increased amount of glucose in the collecting ducts. Further, there is an effect on glucagon, as already mentioned. SGLT2 inhibitors increase glucagon levels, and glucagon is a stress hormone which has a positive inotropic or chronotropic effect on the heart. This may also be part of the beneficial effect. By the way, also with liraglutide, glucagon is increased in the long term. Finally, SGLT2 has an effect on adipokines. We know that perivascular and epicardial fat deposits have a role in the genesis of heart failure, and one mechanism behind this link may be an altered paracrine regulation of adipokines in the myocardium. Here, a recent paper which shows that leptin is reduced, whereas the beneficial adiponectin is increased with canagliflozin here compared to glimepiride. These are currently discussed mechanisms. Nobody really knows what really is the major mechanism. I think it's very likely that the alterations in fluid load play a major role together with probably metabolic effects. But many questions remain open. So some important questions here. Now, first, do SGLT2 inhibitors at all reverse pathological cardiac remodeling in diabetes? This is an important question, and this is not completely sure. So these are preliminary data from a small series of patients where a reduction in the left ventricular mass index has been shown with empagliflozin, and an improvement in diastolic heart function and the ability of the heart muscle to relax has been shown with the medication. But this is primarily, these are primarily results. Further studies are on their way. Then the effect of SGLT2 inhibitors on serum and renal biomarkers has been studied, but by no means has been completely elucidated. So the effect of the medications on proBNP levels in different patient populations need to be studied, their effect on troponin, on mediators of the renin-angiotensin-aldosterone system. The effect of the medications on markers of kidney injury, for example, of kidney injury molecule 1, needs to be studied, and its impact on uric acid needs to be further elucidated. An interesting aspect is the effect of SGLT2 inhibitors on arrhythmias. It has been speculated that the increase of glucagon, for example, counteracts cardiac arrhythmia. Then the impact of SGLT2 inhibition on functional capacity, on the ability of heart failure patients, for example, to tolerate exercise, needs to be studied and is studied in ongoing trials. And the effects of the medications on sympathetic nervous system and neurohumoral activation, of course, also is a topic of major interest. This is addressed in several ongoing mechanistic trials and ongoing heart failure trials, which all have popped up during the past several years. And also there are still 3 upcoming cardiovascular outcome trials. We already know that the DECLARE trial with DAPA has been successful. It will be presented at VHA meeting this year. And the CREDENCE trial with canagliflozin in chronic kidney disease patients and the VERTIS trial with ertugliflozin are also expected soon. With this, I thank you for your attention, and please come along with your questions.